A very good morning to all the respected dignitaries, eminent speakers, distinguished delegates, and dear postgraduate students. On behalf of the Indian Rheumatology Association, Kerala chapter, it gives me immense pleasure to welcome you all to RHEUMACON Calicut 2025 here at the beautiful Ravis Kadavu, Kozhikode. Without further delay, we shall now begin the scientific deliberations of the day. Our first session is titled Organ-Specific Challenge. And may I now request our esteemed chairpersons for this session to kindly come forward and take the seats on the dais.
Dr. Padmaja Raghavan, Consultant Rheumatologist, RHEUMACON, Kannur. Dr. Jacob Anthony, Professor in Medicine, GMC, Thiruvananthapuram. Now we request our chairpersons to kindly introduce the speaker.
A very good morning. We'll start off the session. So for the first session, we welcome Dr. Hari Krishnan ji. He has done his general medicine and DM clinical immunology and rheumatology. He is the assistant professor and head of Department of Rheumatology, Government College, Kottayam. And he has several publications. His areas of interest are inflammatory myositis, systemic vasculitis, primary immunodeficiency disorders. He'll be talking about Sjogren's syndrome beyond Zika.
Good morning, everyone. Thank you, madam, for the kind introduction. I would like to thank the organizers for inviting me here. So over the next 20 minutes or so, I will be talking on Sjogren's disease beyond Zika. So there is a recent change in the terminology of this disease. So it was known as Sjogren's syndrome earlier. So now it has been, the name has got changed. Now it is no longer a syndrome. We call it primary Sjogren's disease. So primary Sjogren's disease is basically a chronic systemic autoimmune disease. It is typically characterized by exocrine gland dysfunction. The hallmark features, as all of you know, includes dryness of eyes and mouth. This disease leads to significant impairment of the quality of life, and the disease has got a wide range of extraglandular involvement. So the focus of my talk will be on the extraglandular disease in Sjogren's, because we are all well aware of the dryness aspect. So coming to the extraglandular involvement, so it is seen in around 20 to 70% of patients. Now there is a wide variation because a lot of studies have used different criteria to define the extraglandular involvement, and this extraglandular involvement may precede the onset of Zika. Okay, so that's an important point to note, and it could be the first symptom of Sjogren's disease. So, and that is where these patients could get misdiagnosed, and there could be a significant diagnostic delay. So it can basically involve any part of the body, as it is shown by this diagram, and we will see the involvement in the subsequent slides. So coming to this Sjogren's Big Data Consortium, this is basically a multi-center, multi-ethnic, multinational study across different continents, which included around 6,331 patients. The aim of the study was to look at the the known SDI features. So SDI basically stands for Euler Sjogren's Syndrome Disease Activity Index. It includes around 12 organ domains, as you can see here. So they have already done a study and looked at the different organs in the SDI, like articular, pulmonary, constitutional, and you have seen the prevalence given here. But the aim of the study was to look at the non-SDI clinical features. So you can see some of the features like Raynaud's here, episcleritis, or something like a dysautonomy, small fiber neuropathy, paniculitis. These are all very rare features not included in the classical SDI domains. So they looked at the prevalence of this, and they found that at least one of these non-SDI feature was found in 26.1% of patients. So this basically shows the burden of the extraglandular non-SDI features. So coming to this case that we saw recently, so this is a 44-year-old lady who came with acute onset flaccid quarter paresis. She had severe weakness and had impending respiratory muscle weakness, severe hypokalemia, and with this background of severe hypokalemia, we thought of a Sjogren's with a hypokalemic paralysis. So we went ahead with a venous blood gas analysis. We showed a normal anion gap metabolic acidosis, and further this patient had very poor oral hygiene. You can see a lot of missing tooth here. She had very poor oral hygiene, though she denied a symptom of Zika. She did not complain of oral Zika or ocular Zika, but this the poor dental hygiene and the other factors made us think of Sjogren's. So ANA showed 3+ speckle pattern and the profile was strongly positive for anti-SSA. So this patient was diagnosed as primary Sjogren's disease with distal RTA. She had increased urinary potassium excretion also, and she was treated with IV KCl. She had a good improvement and she's on oral potassium supplementation. So this basically shows you that primary hypokalemic paralysis secondary to distal RTA in Sjogren's can precede the onset of Zika. Okay, so this case series basically looked at patients who presented to a center with severe hypokalemia. So they had around 42 patients, 42 patients who came with severe hypokalemia, and among these 42 patients, 22 patients had distal RTA, and among the distal RTA, 13 patients were diagnosed with primary Sjogren's syndrome. What is interesting to note is that among these patients, 62% of patients had no signs or symptoms of exocrine gland involvement. Means that the majority did not have any Zika. So we all will face a situation when hypokalemic paralysis will present as the first symptom of primary Sjogren's disease. So coming to the renal involvement in primary Sjogren's disease, so we can see that it is seen in around 5% of patients. So 5% of patients can have renal involvement, and the most common form, as we all know, is the chronic tubulointerstitial nephritis. And the most common manifestation of tubulopathy could be electrolyte abnormalities, distal RTA, nephrogenic diabetes insipidus, and you can also get a proximal RTA in these patients. And the distal RTA could present as hypokalemic paralysis, but we should also screen these patients for renal calculi, nephrocalcinosis, and bone disease, metabolic bone disease, that is osteomalacia. And the glomerular disease is less common and usually presents as a membranoproliferative glomerulonephritis. Now coming to the cutaneous involvement, the most common skin finding is basically a dry skin, seen in around 72% of patients. And you can also see an annular erythema, a polycyclic annular erythema, which resembles the kind of subacute cutaneous lupus that you see in SLE patients. And this skin finding has got a strong association with anti-SSA. And the cutaneous vasculitis is another important skin finding, could be seen in around 10 to 30% of patients. These patients present with palpable purpura, cutaneous ulcers, urticarial vasculitis, or they can even present with skin nodules. The biopsy usually shows leukocytoclastic vasculitis, suggestive of small vessel vasculitis. And the cutaneous vasculitis has got a strong association with anti-SSA. And 1/3 of these patients are positive for serum cryoglobulin, which is basically an important prognostic marker, as we will see in the subsequent slides. And another kind of purpura that you can get in Sjogren's is a hypergamma-globulinic purpura. Okay, so this is slightly different from the vasculitic purpura that you see in Sjogren's, because this purpura is basically a non-palpable purpura or a flat purpura. It occurs with prolonged standing or gravitational forces, and it is usually associated with a polyclonal hypergamma-globulinemia and has association with rheumatoid factor positivity. Raynaud's phenomenon could be seen in around 10 to 20% of patients with primary Sjogren's syndrome. This is less severe than the Raynaud's that we see in systemic sclerosis. So this is one of our patients with extensive palpable purpura secondary to Sjogren's. Now coming to neurological involvement, the CNS involvement is seen in around 5% of patients. Cognitive dysfunction is very common, could be seen in around 53%, and cranial neuropathy, especially that involving the cranial nerve 5, cranial nerve and 8, could be seen in around 16 to 20%. Demyelinating lesions could be life-threatening. Okay, so these patients could present with a multiple sclerosis-like disease. They can come with neuromyelitis spectrum disease. They can have pure optic neuritis, or they can have a demyelinating disease involving the cervical spinal cord or the thoracic spinal cord. The peripheral nervous system involvement ranges from 3 to 15%. It could present with a pure sensory neuropathy, or it could be a sensory motor polyneuropathy. And autonomic nervous involvement is usually underdiagnosed, so it could be ranging from 3 to 50% of patients. So this is basically an image of a patient with a longitudinally extensive transverse myelitis, means the inflammation is spanning for more than 3 spinal cord segments. So coming to small fiber neuropathy, I'll deal with a few of the specific neurological entities in Sjogren's. Small fiber neuropathy is basically can occur as an isolated phenomenon, or it can coexist with a large fiber neuropathy. So this presents with very disabling burning paresthesias, lancinating pain, or allodynia. And it could be either a length dependent or a non-length dependent. Okay, length dependent, we all know the classical glove and stocking neuropathy, or it could be a non-length dependent pattern also. and usually they have a normal nerve conduction study. So when they have a normal nerve conduction study and a non-length dependent pattern, these patients could be misdiagnosed as a psychosomatic syndrome. And the diagnosis is basically clinched by a reduced intraepidermal nerve fiber density, and the treatment is usually symptomatic with anti-epileptic drugs. The immunosuppression has been tried in various case series and retrospective studies, but the results have been largely disappointing. Now coming to sensory ganglionopathy or neuronopathy in primary Sjogren's, this is another important neurological involvement. It could present either as an isolated involvement, isolated impairment of kinesthetic awareness, or a disproportionate kinesthetic lack of awareness. So this is seen around less than 5% of patients. Okay, and the nerve conduction study usually shows a non-illustrable snaps with preservation of compound muscle action potentials. So MRI may show T2 hyperintensity in the gracile and cuneatus tracts of the dorsal or the cervical spinal cord. The treatment response is very variable. Some studies have shown improvement with IVIG. Minimal response to immunosuppressives. We are not sure whether this is due to the long diagnostic delay these patients have. And there might be a case that these patients usually miss the therapeutic window. So there are studies that shows that if you treat them early, within the first 3 months of the onset, there could be some reversibility. And even if the treatment is delayed up to 8 months, you can stabilize the disease. But beyond that, we are not sure whether the treatment will make any significant difference. So coming to lung involvement, prevalence of lung involvement is around up to 25%. And the subclinical lung involvement in the form of abnormal pulmonary function test, abnormal HRCT could be seen around 75%. The tracheal dryness is the most common involvement, seen around 50%. It can present as a disabling dry cough or persistent hoarseness of voice. The chronic airway dryness also leads to recurrent infections, bronchiectasis, and other LRTI. Distal airway involvement is typically characterized by follicular bronchiolitis or small airway disease. And interstitial lung disease could be seen in around 10 to 20%. The most common pattern is NSIP followed by OP and LIP. So this is a classical LIP or the lymphoid interstitial pneumonia. You can see the multiple cysts here. So this is kind of a cystic lung disease, and it could be, when you see this kind of HRCT, always work up for primary Sjogren's disease. So this is a study from CMC Vellore where they looked at the therapeutic outcomes of patients with primary Sjogren's disease. So they found that they had around 550 patients, and around 33 patients had interstitial lung disease. So then they followed up this basically retrospective study. They looked at the therapeutic response at 1 year. So 25 patients were available at 1 year to look at the therapeutic response, and patients were divided into patients who either improved or patients who had a worsening disease, improved or stabilized, or patients who had a worsening disease. You can see the clinical features. The most common kind of ILD was NSIP. And what they found was that the majority of patients, 22 patients, 88% of patients improved at 1 year. Okay, they were responders. They either had an improving disease or a stabilizing disease. And when they looked at the predictors of improvement, the presence of Zika symptoms, NSIP pattern of ILD, and absence of Raynaud's syndrome, Raynaud's phenomenon was associated with the clinical response. Now coming to the hematological manifestations, cytopenias could be seen in around in a large proportion of these patients. It could be anemia, leukopenia, or thrombocytopenia. Hypergammaglobulinemia is usually seen along with active systemic disease, seen in around 40% of patients, and low complements could be seen in around 20%, which is again a marker of poor prognosis. Now coming to the lymphoma in primary Sjogren's disease. So this is one aspect which we are all very scared of, that these patients might develop lymphoma in future. So it is seen in around up to 10% of patients can develop lymphoma. So primary Sjogren's disease has got a 10 to 44-fold higher risk of developing lymphoma compared to healthy individuals. The most common type of lymphoma that we see in this patient is a low-grade B-cell lymphoma, or predominantly a margin zone histological type. So are there any predictors to lymphoma development? Whom should we screen for developing to lymphoma? So the predictors have been identified. It could be either a clinical predictor, biological, or a biopsy predictor. So clinical predictor includes patients who have a unilateral persistent salivary gland enlargement. We all know these patients can get recurrent parotitis or recurrent salivary gland enlargement. But when the pattern is slightly different, when they have a persistent unilateral parotid or salivary gland enlargement, you think of a development of lymphoma. Patients who have persistent lymphadenopathy palpable purpura or a SDI score more than 5. That means a moderate disease activity, moderate to high disease activity. So that is also a clinical predictor of development of lymphoma. Biological predictors include presence of cryoglobulinemia, lymphopenia, low complements, serum or urinary monoclonal component. And the biopsy features have been studied. Basically, patients who have a germinal center-like structures in the lymph node biopsy, patients who have a higher focus score more than 3. These are predictors of lymphoma development. Coming to the GI involvement, dysphagia is seen around 65% of patients, and the most common causes include the xerostomia and patients who having it could be secondary to the esophageal dysmotility. The GI motility disorders could be again secondary due to autonomic neuropathy, gastritis or reduced acid production, and pancreatic dysfunction is underreported. Basically, it is because the pancreatic involvement is subclinical. Okay, it basically involves the exocrine part of the pancreas, and abnormal LFT could be seen in around 50% of patients, which could be secondary to non-alcoholic fatty liver disease, primary biliary cirrhosis, or even autoimmune hepatitis. GA vasculitis is a very uncommon feature of primary Sjogren's disease. When it occurs, it is usually secondary to cryoglobulinemia and could be life-threatening. Now, coming to the musculoskeletal involvement, arthralgia is in around 75%. Arthritis is less common. It is usually symmetrical and polyarthritis, not erosive, not deforming like your classical rheumatoid arthritis. Myalgia is very common, and you should also think of possibility of fibromyalgia or hypokalemia when a patient has persistent myalgia in Sjogren's, whereas true myositis with frank muscle weakness is very rare in primary Sjogren's disease. Coming to the cardiovascular involvement, so this systematic review and meta-analysis looked at a wide range of cardiovascular involvement in primary Sjogren's. They found that the incidence of cardiovascular events, thromboembolic events, heart failure rate, and coronary morbidity is significantly higher in Sjogren's compared to healthy individuals, and the prevalence of pulmonary artery hypertension is around 12.5% of patients. Now, what are the predictors of systemic disease? We have seen the wide range of systemic disease. What are the predictors? So, patients could be divided into 3 categories. They have a low risk category, moderate risk, and a high risk category. So, low risk is basically elderly onset, seronegative and isolated, La antibody positive. Moderate includes ethnicity like a black individuals, young onset disease, and strong antibody positivity. The high risk include male patients who have a high focus score on the biopsy or germinal center formation. They have rheumatoid factor positivity, cryoglobulinemia, and low complements. So this is one way where you see a patient of Sjogren's in your clinic, you can stratify the patient into low risk, high risk, and moderate risk, and then subsequently follow up the patient. Now, comorbidities in so we have seen the wide range of extraglandular involvement. So this disease has also got multimorbidity or a lot of comorbidities. So this is data from the UK primary Sjogren's registry, which had around 931 patients. So most common comorbidity was osteoarthritis, seen in around 36%, followed by GERD. And you can see a wide range of comorbidities, which we also encounter in our clinical practice. So then they looked at the CPS, which basically stands for comorbidity and polypharmacy score. And they found that this score was significantly higher in patients who had a high symptom burden and pain dominant group. So they stratified the patients into 4 groups. One is basically a dryness dominant group, dryness dominant and fatigue. Second was high symptom burden based on symptoms of anxiety, pain, depression, etc. And they also had a low symptom burden group and a pain dominant. So the pain dominant and the high symptom burden group had significantly higher comorbidities. Now, what about the associated conditions? Primary Sjogren's is a hallmark, it's a typical autoimmune disease, so it has a lot of overlap conditions. So the autoimmune thyroiditis, celiac disease, pernicious anemia, hypovitaminosis D, and monoclonal gammopathy of uncertain sequence. These are all associated with primary Sjogren's disease. And the BSR latest guidelines recommends that at baseline we should screen for vitamin D levels, thyroid functions, LFTs, AMA if indicated, TTG. I'm not sure how common celiac disease is here, but they also, it's very common in the Western population, so they advise us to screen for TTG, immunoglobulins, bicarbonate, and creatine kinase. Now, coming to the treatment. So I have only a few slides on the treatment because it's very impossible to cover all the involvement in one 30-minute presentation. So the basic idea of treatment of extraglandular disease is you have to look at the patient as a whole. You have to look at the patient's SDI or the disease activity and then make a decision. Okay, and steroids can be used, but they should be used for the minimum duration as possible. And there is no head-to-head trials or large-scale data comparing the various immunosuppressive or steroid-sparing agents. So that is basically an individual choice and looking at the patient's comorbidity profile. So if you look at something like a cutaneous involvement, so if you have a localized disease, you can treat with topical steroids, and then if it is very diffuse, you can use hydroxychloroquine or GCs or glucocorticoids. So this is just like how you treat lupus. And for cutaneous vasculitis, again, you can have a moderate SDI or a high SDI. For patients with high SDI, you use glucocorticoids or other immunosuppressive agents. For the pulmonary involvement, the bronchial involvement, you basically use inhaled treatment therapy. For the ILD, you basically look at the patient's SDI score. If it is only moderate SDI, you can start with steroids. If it is very high SDI, you can use steroids and other agents like cyclophosphamide, azathioprine, mycophenolate, etc. Now coming to renal involvement, if it is purely tubular involvement with mild SI, you go for symptomatic treatment with alkali replacement and potassium replacement. If the patient has significant high disease activity, you can go for glucocorticoids or other agents like azathioprine or mycophenolate. If the patient has glomerulonephritis with high SDI, you treat it just like how you treat lupus or other vasculitic diseases. Peripheral neuropathy is again based on the kind of involvement. If it is mononucleus multiplex, you treat with steroids followed by azathioprine, mycophenolate, or you can go for cyclophosphamide. If it is ganglionopathy, the first line of agent that is recommended is IVIG followed by other agents like cyclophosphamide if it is non-responding. Now coming to the articular involvement, like how you treat in lupus or RA, you have mild disease start with hydroxychloroquine. If it is very significant, you go for other agents like methotrexate. And if it's still not responding, you can go for rituximab. And CNS involvement, if it is CNS vasculitis, the drug of choice is glucocorticoids followed by cyclophosphamide, rituximab or plasma exchange in refractory cases. If it is multiple sclerosis presentation, you have to consider specific MS therapy. For hematological disease, again, you look at the severity of the involvement. If it is severe involvement, you go for steroids with IVIG, and you can use rituximab or plasma exchange in very refractory cases. So the take-home messages from my presentation is that Sjogren's disease is not just a disease limited to the dryness, fatigue or pain. So the burden of systemic disease or extraglandular disease is quite high. You have to screen for extraglandular involvement in every patient with primary Sjogren's syndrome. There should be a high index of suspicion for primary Sjogren's syndrome in patients with systemic involvement, even in the absence of Zika. So don't just rely on Zika to diagnose Sjogren's syndrome. The treatment of extraglandular disease, the data is quite limited. There is no large head-to-head trials comparing the different therapeutic agents. So the treatment decision has to be taken on a case-to-case basis. Thank you.
Thank you, Dr. Harikrishnan. It was an extensively covered topic. Any questions?
Very nice presentation. You were detailing regarding the extraglandular disease. No, if you want to treat the glandular disease, recurrent parotitis, how do you like to treat? Like, no, the patient is coming to you, they have recurrent parotitis. You will leave it like that, or you treat it only recurrent parotitis with Zika, no extraglandular.
Okay. So recurrent parotitis, you can use NSAIDs or short course of low dose oral corticosteroids, and if it's still not responding, you can use your DMARDs like methotrexate. And for the Zika part, there are multiple trials using agents, when using strong agents like rituximab, but the results have been very conflicting. There's no consistent improvement with these agents, though there has been improvement in the tear flow rate or the salivary gland flow rate. The patient reported outcomes has not been very promising. So it's plus minus. But for the parotitis, you can, if it is bothering the patient, you can treat with NSAIDs or low dose glucocorticoids.
What is the dose of rituximab you give? Like weekly once or every 2 weeks apart, or what is the dosing schedule?
So for induction dose, we give 2 doses, day 0 and day 15. The dose can be either 500 milligram or 1 gram. So that is basically based on the clinician's judgment. For severe involvement, we can give 1 gram 2 weeks apart, and then give maintenance regime every 6 months of 500 milligram.
And what is the protocol for cyclophosphamide?
The cyclophosphamide, if you have severe extraglandular involvement, like a vasculitis, you can give a 15 milligram per kilogram cyclophosphamide. So that could be given monthly for 6 months.
Excellent talk, Dr. Harikrishnan. We do see a lot of unexplained neurological problems, no? Where people, when investigating anti-Rho positivity, without much Zika symptoms, do you consider them as having Sjogren's, or how will you proceed?
So, sir, we actually, it's a very common scenario. So, we follow up these patients. The treatment does not change much actually. If you have a patient with a, for example, LETM, transverse myelitis with antibody positive, anyway the neurologist would be going for immunosuppression. So, we also advise them to follow the same thing. Then we follow these patients up. These patients might develop Zika or other glandular or other features of Sjogren's in the due course of time. So we follow up these patients, we keep them under follow-up, but the initial management does not change.
As always, a very good talk, Hari. My question is on your approach to the management of tubulointerstitial nephritis and Sjogren's, and what is the evidence base for using immunosuppressants in those patients?
Yeah. So, very good question. Again, this is kind of a gray zone where people have used immunosuppressants and shown that immunosuppressant use could reduce the usage of, or you can move away from lifelong potassium supplementation. There is some data on that, but there is also contradicting data where people have used that and there has not been much of a improvement, whether it's regarding the progression of the renal disease or whether it's respect to the use of potassium or alkali supplementation. So in my personal practice, I look at the proteinuria. If there is proteinuria, significant proteinuria, I go ahead with the renal biopsy. And if there is a glomerular involvement, if there is a glomerular nephritis, I surely give immunosuppression. And if there is significant tubulointerstitial inflammation with significant proteinuria, especially more than 1 gram, even then those cases I would like to go ahead with your immunosuppressants like a mycophenolate or azathioprine along with steroids. But whether it really helps the patients, I'm not very sure, but there is contradicting data on this.
Excellent talk, Harikrishnan. Do you recommend pilocarpine for all patients with Zika symptoms?
Yes, for oral Zika, yes, we do give pilocarpine.
For all patients?
Yes, all patients with oral Zika. Thank you.
Thank you, Dr. Harikrishnan.
So very good afternoon, good morning everybody. The second topic today of this section is regarding the aorta in the role of PET scan. So quite often we come across aortic diseases, aorta involvement or large vessel disease in our day-to-day practice. So the PET scan is coming along the way for the diagnosis and management of large vessel vasculitis. To enlighten this topic, we have an eminent speaker, none other than Dr. Ashwin M. Nair. He is the senior consultant in rheumatologist, Travancore Medical College, Kollam, and senior consultant in CM Hospital, Pandalam, and Muthoot Hospital, Pathanamthitta. And he has several publications, and his area of interest is inflammatory myositis and early arthritis. Over to Ashwin.
Thank you, sir. Thank you, chairpersons. At the outset, I would like to thank the organizers for giving me this opportunity. This time I'm given a different task to basically talk on imaging, particularly an imaging which we consider is quite expensive, which is maybe out of a league in evaluation of our patients. But let me just take you through the utility of PET in our routine practice. So I'll start off with this one consult which I got from our medicine department. It's we were just joking a few minutes back that if you don't understand anything, just send it to rheumatology and the rheumatologist will handle it. The same thing. This is my senior consultant in medicine. He called me up saying that, Ashwin, I have this lady, a 67-year-old, with pyrexia of unknown origin, defined as more than 3 weeks of fever with no localizing signs or symptoms, just weight loss and a persistently elevated ESR and CRP, saying that there's something going on over there. Now, this patient complained of a generalized malaise, and she was saying she was feeling very sick, fatigue, and a vague right-sided thigh discomfort and pain. Karap is what she was basically saying. Kaala vechu nadakam vayya. That's exactly what we're saying. So when we have it localized to one particular limb, we think of something localized. But all sort of workup was normal. The blood examination, infections, infective workup, bloods, localized Dopplers, ultrasound, everything was negative. And even the CT thorax abdomen done was also normal. And that's when we suggested go on with a PET CT. And this lady showed, very surprisingly, a very localized long segment uptake in the femoral artery. This patient was treated with steroids, and the fever subsided, ESR and CRP crashed, and we are looking at some sort of vasculitis. So if you look at the crucial role of imaging, imaging has a very crucial role in the diagnosis and managing aortic diseases. We have a humpty number of imaging modalities which we can use, and it is very helpful not only for diagnosis but for risk stratification, therapeutic planning, long-term surveillance. So what are the imaging modalities that we can use? We have CT angio, which all of us are comfortable with. Gives excellent spatial resolution, rapid acquisition, so you have a patient coming acutely, you can get it done. 3D reconstruction is readily available, and in case you're looking at an aneurysm or aortic dilatation, that's your investigation of choice. But definitely there's a lot of radiation exposure, you have to use iodinated contrast, so risk of little nephrotoxicity. The other modality which we have is definitely MRI. Now this takes a lot of time and little expensive as compared to CT, but the contrast, particularly when we're looking at peri-aortitis, the peri-aortic tissue, it's very helpful. What about ultrasound? Very limited use in the rheumatology setting at least. It's indicated for cranial GCA, for giant cell arteritis, but not for anything else in the vascular imaging. So then comes the role of hybrid imaging, and there we have PET CT, PET MRI. What are the drawbacks of just using PET alone? Why not use PET alone? The drawback with PET alone is it has very, very poor spatial resolution, about 4 to 10 mm, and poor temporal resolution as well. So you tend to skip or even miss findings or lesions. Now, the problem with PET CT, if you say, is it's expensive, the cost, and the problem is less accessible. And also, the number of radiologists who actually can report PET CT authoritatively is quite negligible. So this is why we need PET. It offers both the high resolution, it combines the resolution of CT and the molecular aspect of PET, and can simultaneously reveal the anatomical, molecular and functional information, provides diagnostic accuracy, localization of many lesions, and can distinguish between an active and a chronic lesion, and also versus an infectious versus a non-infectious lesion. And that's exactly what we need. Now, CT and MRI are okay in the assessment of structural abnormalities, but we want to pick up patients before they develop these structural lesions, and that's where PET CT comes in, because metabolic changes precede the anatomical changes which occur. Now, the utility of PET is not only in that, it also is when the other imaging modalities kind of underestimates the extent of disease activity in PU when there's no localizing signs and symptoms like the patient which I just, and in this particular, like CT angio, we can screen the entire arterial bed and also for early detection of relapses. So these are some of the utilities of PET CT. The radio tracers which are used, we have the most common FDG, that's the 18-fluorodeoxyglucose. This is the most widely used, at least in imaging of aorta. Radio-labeled glucose analog is what it is. Here, what is the science behind this is metabolically active inflammatory cells like monocytes, other inflammatory cells infiltrating into the arterial media and adventitia utilize this glucose more than other tissues, and that's where the uptake comes. Now, this increased FTG uptake correlates very well with active inflammation, extracellular matrix degeneration, as well as cellular infiltration. Now, there are so many other radio tracers which are under evaluation, which are still in the study phase, hasn't come out into daily practice. Now, coming to the other part, what are the aortic diseases which can occur? There are so many aortic diseases, but today I'll be restricting my talk on just the inflammatory diseases as opposed to the others. So what is aortitis? Aortitis is basically a large heterogeneous group of disorders characterized by transmural aortic wall inflammation. Now, there are so many causes. You have large vessel vasculitis, many of our connective tissue diseases, rheumatoid, SLE, spondyloarthritis, anchor vasculitis, Behçet's, Cogan's, all these things can cause aortic involvement. Infections, tuberculosis, which is very common in our country, syphilis, salmonella, all these can cause infectious, and also it could be a manifestation of a multisystem disease like sarcoid or IgG4 related disease, or it could be just something idiopathic. Now, I just thought I'd put up 2 slides on how to prepare a patient for PET-CT. So it's not just that we send our patient for PET-CT. What are the instructions as a physician? We'll all think that the radiologist over there, it's not his or her duty. It is our duty also to know what all to instruct while sending a patient for a PET-CT. Ideally, they have to consume a low carbohydrate diet 24 hours prior to FDG uptake, no strenuous exercises at least 24 hours prior to the test, fast for a minimum of 6 hours to decrease the physiological. So all this preparation is basically so that the other tissues don't take up the FDG as compared to the lesions which we are interested in. And also the patient should completely relax after the FDG so that there's no uptake within the skeletal muscles. Now, we all often see our radiologists say, what is the blood sugar prior we getting the FDG? The blood glucose level should be below 125 milligram per deciliter. Preferably acceptable one is less than 180. This is so that unnecessarily normal glucose is not taken up. Now, the question is, can I continue steroids in our patient which we are taking FDG? Preferably better to stop, delay treatment, or if started, give a break. Usually PET is done within 3 days of initiation of steroids. Anything more than that can affect the outcome of our study because we are comparing it with a liver uptake. Positioning, we basically ask the patient from the vertex all the way to the mid-thigh and or lower if possible. In the supine position, the patient is laid with the arms next to the body, and the timing is basically the study should be for 60 minutes after the FDG administration is given. Studies have compared 60 and other timings, and they found that if you extend it to 120 minutes, the uptake, particularly in vasculitis, and that's our focus of interest, is better. That is where this delayed treatment protocols come. Here what they do is they basically try to acquire images after the blood pool activity just comes down a little bit so that the arterial wall is visualized as FDG uptake is there within atherosclerotic plaques, and we have to distinguish between a lesion and an atherosclerotic lesion, and that's where such treatment protocols come into play. So the concept of PET-CT in aortitis is basically we are looking at the inflammatory cells, particularly monocytes within the aortic wall. Now, what are we looking for? And that is with this term, standardized uptake value, SUV, and is basically compared, this uptake is compared with that of the liver. The potential PET-CT in aortitis is basically what all I said. There's longitudinal assessment, response to treatment, ability to assess the periaortic activity, and also as targets for biopsy. Now let us look at the giant cell concept. So in giant cells, involvement of the large cells, the extracranial giant cell arteritis is basically what it is. Seen in about 25% of the patients. Aortic involvement is very typical. And if you look at the spectrum, in this particular study, they had 45% of their patients having aortic involvement, predominantly involving the thoracic aorta. And these patients were more prone for aneurysmal growth at a much faster rate as compared to degenerative aorta. And not only that, they had a risk of dissection as well, particularly when the aneurysm was less than 5 centimeter. And that's something that we have to probably look in our patients. So why PET? And these are the statistics. If a new patient of giant cell arteritis comes, 50% can be diagnosed by ultrasound, 65 with CT angio, but look at the values of PET, almost about 83%. If you want to do a CT, yes, because it's almost in par according to the study, they have similar sensitivity. But in case of relapses, it's always a PET CT which is doing much better than a CT angio. It has very good sensitivity and specificity, very it's sensitive to extracranial vasculitis, but not for the intracranial vasculitis like I told earlier. Very useful for localization of the extent of the lesion and early detection. Now, this is basically what you see in giant cell arteritis. Linear, homogeneous, circumferential pattern of vessel wall involvement, involving the arterial walls and the branches with a similar intensity to that of the liver. Now, this was another very interesting finding which I actually, while I was preparing for this, a tree root-like appearance, particularly involving the lower limb vessels. And this was quite new when I was preparing for this talk. Now, physiological uptakes are there in the brain, the neck muscles, myocardium, the kidneys and the bladder. So you see something lit up there, please don't think that it's a lesion. These are normal physiological uptakes which are seen. All these things are possible: damage assessment, monitoring, response to treatment. What about the Takayasu concept? Takayasu PET-CT may have a role. It allows differentiation between active and inactive recurrences, and also, but the utility of TAC in Takayasu comes when you have to detect pre-stenotic lesions, and that is something that only a PET-CT can pick up. Picking up inflammation prior to a structural change occurring, and that's basically what we want. Now, disease activity assessment is possible with PET, and they also do have a role in longitudinal monitoring, but it has its own limitations. Now, this was a study which was done from PGI Chandigarh, which was published in 2014, which says that in our concept, these are not foreign data, this is all our data also. It has a high sensitivity, PET has a high sensitivity for detecting aortic lesions, even during immunosuppression, and may actually help in guiding therapy and assessing response to therapy. So these are representative diagrams which I got from another study. You see the lit up aorta before treatment and after treatment, and that's something basically what we have to look in for. So what is the difference in the PET appearance? The PET appearance between GCA and TAC, there is a small difference. Diffuse FDG uptake in the thoracic aorta without associated damage could represent GCA more than TAC. Now, other involvements like carotid, mesenteric, renal involvement more common in TAC, and temporal artery obviously is less common. Ocular arterial system is rare in TAC. So this is basically what I was saying. The diffuse aortic involvement, if you can see, the diffuse aortic involvement in GCA as opposed to just the aortic arch and bilateral carotid involvement which occurs in TAC. This is the difference in the uptake when you see GCA and TAC. So what is the utility? Clinical symptom, that it's useful for at the time as a diagnostic tool. It can be used for monitoring as a disease activity. It's not advisable for monitoring disease activity as of now, but probably in Takayasu's than in giant cell arteritis. Even prognostication may be having a limited value. So currently PET-CT, the role is more for diagnosis. Probably we need more studies on follow-up monitoring as well. Now, I just thought I'll spend some time on these scoring systems which are available. Now, there are several scoring systems which are qualitative and semi-quantitative, and that's where this PET-VAS and TVS, which are qualitative scoring systems, and then you have semi-quantitative, and that we are all aware of. SUV, target to background ratios, all these things have come up. So this is basically the difference in the scoring system. The qualitative is just a visual assessment, and that basically depends on the expertise of the radiologist who is looking, wherein it's compared to either the background tissue such as the liver, And semi-quantitative is actually quantifying, and that is, it's based on the region of interest and constructed by the PET-CT, and we determine how much is the standardized uptake value. And there's something called as a target to background ratio, which is very, very important when assessing vasculitis, and probably that is something which we have to ask a radiologist to probably look into. Now, this is this thing of just of what PETWAS is, a visual assessment wherein each of the arterial territories is scored 0, 1, 2, and 3, and a summative score is basically brought out. There are studies which have looked, and these are recent, relatively recent studies, which have compared both, and they've found rather than this visual, it's always better to do semi-quantitative rather than the qualitative studies. Now, the same thing applies when we if we take just the PETWAS alone, that is the visual assessment alone, it does differentiate between an active and a chronic disease. But if we have to look for relapse, PETWAS is not doing very well in these studies. So that's why in 2024 comes the development of the Takayasu Arthritis Integrated Disease Activity Index, and which is basically a hierarchical system where whether the patient has symptoms, then it's given a point. In the same, they have a vascular territory involved, there's raised inflammatory markers, then the patient is given a score. Now, how do we distinguish it from atherosclerotic lesions? And that is basically what our whole, can this all be? We have our previous patient, 67-year-old, can this be atherosclerosis rather? Now, atherosclerotic uptake on FDG is usually a lower intensity, a patchy pattern compared to the smooth linear pattern, and frequently involves the iliofemoral arteries. Now, usually in vasculitis, it is a concentric wall involvement, confluent uptake throughout the arterial territories, and greater uptake in the arteries above rather than below the diaphragm. And so these are the telltale differences between atherosclerosis and vasculitis. So please keep this in mind when you have lit up aorta coming next to you. You can also use sodium fluoride tracers are also used along with the FDG. Why? Because sodium fluoride basically picks up calcium. So it's a marker of increased vascular calcification, which can lead to vascular microcalcification. So we have to look, and this is another tracer which is used for the evaluation. Now, another area of interest is in IgG4 disease. Now, this may account for nearly half of all the inflammatory aortic aneurysms, and what you see in IgG4 aortitis is again a hypermetabolic diffuse circumferential thickening with homogeneous wall involvement with or without aortic root dilatation. But here, it's not only the aorta, there's also a periaortic uptake which is seen in IgG4 disease. This was a study which came out in 2007 where they delineated which are the various territories which are involved, and IgG4 as opposed to giant cell and Takayasu predominantly involves the iliac arteries followed by the infrarenal abdomen. Other manifestations, we can have periarterial enhancing soft tissue thickening which is seen in IgG4. We can have pseudotumor formation around the vessels. Also, there could be infiltration into the pericardium and also as cardiac masses, which are various findings which are seen in IgG4. Now, something to keep in mind is that IgG4 aortitis has a high risk of developing aneurysm, and that too rupture, particularly when the patient is on steroids. So please be careful, and this patient should be followed up carefully if you have an IgG4 related aortic aneurysm. Now, this particular entity, and I'll stop with this, is isolated aortitis. Now, this is an entity which was given a nomenclature in the 2012 Chaplain-Hill nomenclature, where this is now classified as a single organ vasculitis, clinically isolated aortitis, and that is what the term is. Most commonly seen in women in their 6th or the 7th decade of life. How do you make a diagnosis? It's usually histologically when they undergo some surgery, aortitis is diagnosed, or the presence of aortic inflammation either on MR, CT or PET. They can have histologically 3 patterns, either granulomatous, lymphoplasmacytic or suppurative. And you do all these umpteen number of tests basically to rule out all the differentials which I was talking to you about in the last few minutes. SLE can also have, and this I just took as a representative image, of all the other connective tissue disease. Now, even if in SLE, it's predominantly the thoracic aorta which is involved, usually seen in males with an SLE diagnosis greater than 3 years with hypertension. It's possible that the patients can develop. So the gist of it is basically when we are looking at our patients with aortic, we have to choose wisely on which particular imaging modality to use. Just because PET-CT is a little expensive, it's probably worth because we get a diagnosis and we can treat, and it gives an idea whether, particularly if when we need to distinguish it between an infectious and a non-infectious cause. So please choose wisely on the imaging modalities. Don't be happy just by thinking that CT and MR is negative and this patient doesn't have this particular condition. Thank you.
Thank you, Dr. Ashwin, for the nice, lucid, crisp description of PET scan, role of PET scan in aortic diseases. The topic is open for discussion.
Sir, very nice talk. Just a couple of doubts. One is regarding the steroid dose. As you told, one area where we do PET-CT is to look at the disease, monitoring of the disease. So when you have a patient who is on, let's say, tapering dose of steroids, something like a 15 milligram or 10 milligram, and the patient has some features of active vasculitis, and we want to do a PET-CT. So there is a concept that steroid dose more than 5 milligram can mask the vascular inflammation. So what do you do in your clinical practice? Do you reduce the dose to less than 5 milligram and then go for a PET-CT, or?
Yeah, I put up that particular statement just because of that, because this dose of 5 is actually not given in any of the guidelines as such, and this is basically it's an expert opinion. This 5 milligram is just an expert opinion, and I think that's a fair enough dose when we are, because some amount of uptake, and that correction has to be told to the patient is on a low dose of steroid, has to be told to the radiologist, because any small uptake should be taken significantly as such. But that becomes a little tricky when we are managing Takayasu patients, because even the stenotic lesions sometimes do have a little bit of uptake. Probably there's no inflammation in it. So, or we are losing out some subclinical activity which is going on in there, and that is the gray zone which lies in PET-CT.
So do you reduce it below 5 and then go for a PET-CT?
I do go to the minimum dose possible,
and then
probably
go for a PET-CT.
2.5, yes.
And any particular indication where you go for a PET MRI compared to a PET-CT?
I don't have this thing for a PET MRI as of now, so I am doing PET-CT. I have no experience with PET MRI, but I think what the literature says is that PET MRI is doing much better than PET-CT, particularly in IgG4, and also when we are looking at the soft tissue component of all these conditions, PET MRI is definitely doing better than PET-CT.
Thank you, sir.
We have been doing PET MRI. I think the soft tissue component, as you said, the vessel wall thickening and other stuff is much better with PET MR when compared to, so in Takayasu. But always do whatever modality. If you have done a CT PET initially, after 5 years you want to repeat this, do the same. So
repeat the same.
That makes more sense than doing a PET MR. But PET MR is definitely helpful.
Yeah, about this, I've got one doctor. He's about 74, 75. He has been clinically diagnosed as polymyalgia rheumatica.
Yes.
But he is scared of starting steroid. So just now I told him, why don't you go for a PET MRI before starting?
Yeah.
Is PET MRI recommended to all cases of, if they can afford, should we do for all cases? Because they see the joints also is, the uptake is
very
in
good
the joints
PET.
plus in the vessels.
Since it's a high, depending upon the clinical scenario, so if you're strongly convinced that this is polymyalgia rheumatica, I won't say all, but yes, it would be beneficial for patients to undergo, because the extracranial component is picked up. Many patients don't have any symptoms as such. So in such patients, PET, CT or MR will definitely, it'll pick up the joints as well as the vessels. So we are actually changing the diagnosis then. So that's why I put up the last slide. So I think non-invasive ones, CT angio or MR initially probably, and then, or if depending upon the accessibility is a very important. Not only that, sir.
Please talk in
That's. That's if it's affordable, I think yes, sir. Because the information which we get with PET MR is much more than what we get in this thing. So.
Ashwin, nice talk. I have a doubt. You said that I saw it conflicting. Is there any definite role for PET in assessing the disease activity post treatment? Because is it different from tachyarthritis and GCA?
Yeah. That's the gray zone which I was talking to you about, and that's the columns which I put up. Recommendations to follow up. It hasn't come into the recommendations so far, because again there's a lot of gray. There's a lot of conflict into it. It requires standardization. Why? Because even the stenotic lesions can have some uptake. So whether are we actually dealing with subclinical uptake over there, or is it some SUV which we can determine, or a cutoff? Studies are still going on in that particular. So
between Takayasu and
giant cell arthritis, yes. Because giant cell arthritis, lesser of stenotic involvement. Not only that, Takayasu is generally considered to be a younger onset condition. So in such cases, there are more of atherosclerosis, there are more of stenotic lesions, more of vascular damage which has occurred. So in such cases, probably a little. But in giant cell arthritis, you're dealing with more of a less, which has started something from much more recent. So here damage component is much lesser, and you're actually looking at the activity component, and that's basically why they've said it in that particular table.
Ashwin, how early we are here?
Sir, sorry.
How early we will do the PET CT in case of aortitis before the aortogram? Aortitis. So how early you will put the CT?
So if you ask, if I have a patient with suspected Takayasu, I would definitely do a PET CT if the patient is affordable as soon as possible.
Before aortogram?
Before the aortogram, sir. Because CT angio, and if you have a PET CT, we don't need an aortogram actually. And that will give us the whole arterial territory from top to bottom, involving the neck vessels, everything. Even the intracranial vessels can be seen. With the advanced imaging modalities available now, it's quite useful in assessing the disease activity.
So because of lack of time, I thank the organizers for giving us to chair this wonderful section. Thank you very much. We just close the section.
So once again, we're thanking both our main speakers, and also thanking our chairpersons, Dr. Padmaja Raghavan and Dr. Jacob Anthony, for chairing the session.